Good morning, good afternoon, good evening, depending on where you are around the world. I have again the pleasure to welcome all of you for a new IATH Junior Clubs, an initiative of the International Academy for Clinical Hematology, dedicated to the discussion of clinical case of interest. And today we have the pleasure to have Dr. Nicolas, who is an assistant professor in the Department of Saint Antoine Hospital, that will discuss a very interesting case of anti-BCMA bispecific antibody for myeloma relapse after previous anti-BCMA CAR T cells. And as an expert, we have Professor Mohty, that I don't need to present, that you all know, and I am sure that we will have some very exciting discussions. Just as a reminder, don't forget to send your question in the chat. You can ask any question in the chat, and after the presentation, we'll have plenty of time to discuss and to take your questions. So please, Nicolas, you can start.
Okay, thank you very much, Florent. Thank you, the IATH, for the invitation. It's my pleasure to present the journey of a young patient with multiple myeloma who relapse after CAR T cells treatment. This is my disclosures. So the story begins in 2012 with a young woman of 46 years old with no comorbidity who presented at the diagnosis pain of the thoracic of the chest and the scanner, the IRM, showed a soft tissue lesion who begin at T3 and finish to T6. In the context, multiple biology show a protein electrophoresis with IgG kappa gammopathy at 53 grams per liter. And we complete the exploration with a bone marrow aspiration who showed a dystrophic plasma cell infiltration, and the karyotype revealed high-risk cytogenetic abnormalities with a deletion 17p. Okay, so this patient of 46 years old was diagnosed with a symptomatic IgG kappa multiple myeloma with a ESS score at 3 and high-risk cytogenetic. So the treatment begin just after the diagnosis with 3 cycles of VTD, which permit to obtain a partial response, and we complete the treatment by an autologous stem cell transplant conditioning by melphalan high dose, and we complete the treatment by 2 cycles of VRD to consolidate the response, and finally the patient was irradiated in the residual soft tissue lesions. The total of this treatment permit to obtain a complete response, but in the final imagery, IRM, we detect persistence of soft tissue lesions. The PFS in this setting was approximately 2 years, and in May 2014, the patient showed a new progression of the gammopathy. So we treated with a salvage therapy by a combination of lenalidomide and dexamethasone, which rapidly permit to decrease the gammopathy. So we conclude in June 2017 with a new complete response, but in the IRM, we showed the persistence of soft tissue lesions. The PFS2 at this step was 4 years, and in March 2018, 2018, the patient present a new elevation of the gammopathy with a need of new treatment. And we, at this time, we propose a new salvage therapy with carfilzomib, dexamethasone in the context of the clinical trial. We obtained a very good partial response until June 2020, and rapidly the gammopathy reappeared, and we propose a treatment with pomalidomide, but the patient don't tolerate this treatment with neutropenia, with a severe neutropenia and digestive intolerance. So we stop the association of carfilzomib, pomalidomide, and dexamethasone. In June, we conclude to a new progression of the disease, and we discuss the addition of daratumumab to propose a treatment, daratumumab CADI. So this is in June 2020, and rapidly in August 2020, the patient present a new progression with a PET scanner, who showed new extramedullary localization with hypermetabolic lesions in the bones, pleural lesions, lymph nodes, liver lesions. So we stopped the treatment with daratumumab CADI and proposed a treatment with ixazomib, bendamustine, and dexamethasone. Unfortunately, the treatment don't permit to obtain a response, and the patient was in stable disease status, and we rapidly propose a salvage treatment with melphalan-flufenamide, but this treatment failed, and the patient was actually at this step in a stable disease. Totally, at the total, the patient received 5 lines of treatments with situations of pentarefractory high-risk IgG-kappa multiple myeloma. And this patient can receive an infusion of autologous anti-BCMA CAR T cells, ID cells, in December 2021, when your center was open to this procedure. And these patients received the lymphodepletion with cyclophosphamide and fludarabine, and the D0 of the infusion of CAR T cell was the 1st December 2021. The few weeks or few months after the infusion of CAR T cell, we rapidly show the decrease of the gammopathy with a complete response obtained after 3 months, and in the same settings, in the same times, the patient obtained a metabolic response with the very good partial response in terms of metabolic lesions, but likely persistent and soft tissue localizations. So in March 2022, the patient obtained a complete response in the hematologic and metabolic points. But in September 2022, in the context of a very short surveillance, the patient showed the new progression with a new increase of the IgG-kappa gammopathy and a new progression in the metabolic lesions with a new localizations on the bone, in the pleural site, and lymph nodes. So this patient was in response during finally 3 to 6 months to rapidly relapse. In the setting, we discuss which treatment can be proposed for these patients, and we decide to use a new treatment, which is a bispecific antibody targeted BCMA, and which is called elranatamab, and we administer the first administration of elranatamab was 13 October 2022. And you can show that the administration of elranatamab permit to rapidly obtain a new complete response very rapidly and a sustained complete response in the PET scan, and all the metabolic lesion disappear rapidly, because in 2 months, the patients obtain the complete response in the hematologic evaluation and in the TEP scanner exam. So in the context of this story, we can conclude that the BCMA CD3 bispecific antibodies are an effective salvage therapy for these highly refractory patients, including in this survey pre-exposed treatment with anti-BCMA targeted therapy, and the response occur very rapidly, with a well-tolerated safety profile, because this patient present no hematologic toxicity and no viral reactivations. Actually, they are in complete response after 6 months of treatment, and the new evaluation with a PET scanner is very good.
So thank you, Nicolas, for presenting this for this very comprehensive presentation of this clinical case. And this is very appealing. This story with this patient that receive anti-BCMA CAR T cell that respond, we lose the response, and after we would expect that if we treat again with an anti-BCMA bispecific monoclonal antibody, we lose the responses, and it raises a lot of questions. And in fact, we already have 1, 2, 3, 4, already 4 questions, and people are sending some questions through the chat. So we'll try to take all of them. But I think right before we are going to discuss the last line of treatment on the sequence with the anti-BCMA treatment, it could be interesting to go back into the story of these patients, because when we look at the first line treatment, she received VRD inductions on single auto with the patient high risk, ISS3, high risk cytogenetics. It could have been a good idea to perform a tandem auto. What do you think about that? Mohamad,
Well,
you can say something.
Yeah, no, thank you very much, Florent, for the invitation, and thank you, Nicolas, for the nice presentation. And indeed, this is a very nice case highlighting, I would say, the revolution that is currently ongoing in the field of multiple myeloma, especially with the advent of these bispecific antibodies, because actually, I know this patient, and the good news is that she was 46. Now you add another 11 years, and she is 57, and her son, who was 10, is now in college doing his university. It shows how amazing are these advances. So going back to your question, Florent, well, actually, initially, I must confess that I proposed to her to do a second auto, because I thought that with extramedullary localization, soft tissues, but also the high-risk cytogenetic deletion 17p, a second auto would be appropriate. Although I must confess that in 2012, we didn't have the EMN trial data and the HOVON suggesting that double auto would be a preferred or a good option for this kind of patient. So spontaneously, I proposed this to her. However, she refused, because actually she didn't like the first auto. And this patient is an artist. This is her job, and she always travels, she tours around. And I must confess also, she's not very compliant, by the way, because Nicolas presented her in a very gentle manner, but it has been always a fight with her to get her to her appointments and to the treatment. But I agree, today, you're right raising this question, Florent, that we would probably, and we continue to propose double auto to these high-risk cytogenetic patients. Of course, this was at the era of triplet induction, VTD or VRD or even VCD in the HOVON trial. We don't know whether double auto is a relevant treatment today at the era of quadruplet induction if you're giving DARA VTD or DARA VRD. We don't have such data. Also, spontaneously, we continue to recommend or to propose a second auto for those high-risk cytogenetics.
Yeah. And we could also have discussed to perform the second auto at time of relapse because she don't receive any lenalidomide maintenance therapy and she was in complete response for 2 years. But I think she also refused to have the second auto at time of relapse, just to close the debate, because she had a bad experience with the auto, and we can understand that.
But then, Florent, please allow me, again, this is important to the audience, that while today lenalidomide maintenance is standard of care, in 2012, at least in France, it wasn't approved as a standard of care. And this is why she didn't receive it. That's one important. The other part, retrospectively, looking into her response actually to the first auto, I do not have much regret, I would say, not offering the second auto or even the salvage auto, because apparently she's not very sensitive to chemotherapy and to alkylating agent.
And in fact, it was very impressive to know that as second-line treatment, she don't receive a triplet at that time, but only lenalidomide dexamethasone, and she stayed in response for almost 3 years. And this is also a very impressive result for high-risk patients. So sometimes we can do well also with less treatments, but of course, it is no longer standard of care. And in this patient now, we will use daratumumab, lenalidomide, and dexamethasone. So the field is moving very fast, we know. So now if we go back to the last years of this patient, so we decided to perform the CAR T cells, and we have raised some question after the CAR T cell failure. We have a question from Dr. Omel, why we don't use talquetamab. So talquetamab will target the GPRC5D, so it's another target. So it could be good to have another target, because maybe it doesn't work with the CAR T cell because there was some issue with targeting BCMA. So why, Nicolas, we didn't decide to use talquetamab to target the GPRC5D at that time, and that we use an anti-BCMA bispecific?
Okay, this is a good question. Actually, at the time of the relapse, after the CAR T cell treatment, we can't include this patient to receive the talquetamab. And in the other hand, we have some data who show that the BCMA expression was very stable in many patients in the context of the relapse after CAR T cell targeting BCMA, and we made the choice to propose the treatment to these patients because we have the treatment with elranatamab actually in the past in the setting of a clinical trial.
Yeah, so yeah, you are right. In fact, there is a question of the drug accessibility, and of course, it could be, yes, very exciting to use here. We target BCMA, we should target GPRC5D, but in fact, talquetamab is not accessible in France and in most countries within any compassionate use programs and so on, and is only available in a few clinical trials in a few sites. So we can't offer these drugs to this patient. This is the reason why we decided to treat the patient with what we the drugs available, and it was elranatamab that was accessible at that time in a compassionate use program in France. So it is the reason of this choice. And I don't know, Mohamad, if you can comment on the sequencing of the use of bispecific targeting BCMA after previous CAR T cells.
I think the point raised by Dr. Jim O'Mell is very important, because in theory, and if you want to follow some scientific rationale, you would say, okay, we have used an anti-BCMA CAR T cell, and at time of relapse, you would like to switch gears and go to another tumor antigen. And GPRC5D, for instance, can be a good candidate. Of course, you're right. At this time in 2021, she wasn't eligible to a talquetamab trial, and we didn't have any compassionate use of talquetamab or any other GPRC5D targeted agent. And one may wonder whether the BCMA signaling pathway remains active in these patients. And I agree with Nicolas that although there were cases of loss of expression of BCMA that were described after CAR T cells or even after bispecific, in general, the expression of BCMA is quite well preserved. Also, we don't check for it, and there is no clear recommendation to check for BCMA expression. In the case of GPRC5D, it is well established that at time of resistance, at time of progression, the patient lose the expression, the plasma cells lose the expression of GPRC5D. It may not be true in the case of BCMA, because BCMA is a member of the TNF receptor superfamily, which is really crucial to the survival of the plasma cells. So one would assume that anyway, with an aggressive malignant plasma cell proliferation, you will still have BCMA active. And actually, it proves to be correct in this situation. The issue is your question, Florent, about the sequence and why we didn't use bispecific before CAR T cells and we use CAR T cells. Well, I think most of us would agree. I mean, at least the patients, they want to have CAR T cells. Everybody's convinced that all the patients come and claim they want to have their CAR T cells. And we see this not only in our center, but I think across the globe. And the tolerance of CAR T cells were rather good, and she responded. However, the duration of response was closer to what we have seen in the KarMMa trial, the registration trial. So I would say, well, nothing, I would say, wrong happened there. However, what we didn't mention, and I think you alluded to this, maybe Nicolas, very briefly, is that the bridging treatment to CAR T cell is extremely important. And it's a learning curve. And for instance, she received melflufen in a compassionate use access, but actually the first apheresis session, I think, failed. And we had to wait for another couple of weeks to get the right apheresis product. And this is maybe important for the community to be aware of, that the type or whatever choice of bridging therapy is going to be important, and it can impact the manufacturing of your CAR T cells. So we believe that whenever possible, CAR T cells should be an option and then switch to BCMA. However, I agree that in the real life and in general, now with the ease of use of bispecific antibodies, many patients are receiving actually bispecific antibodies first. So there is a big gap between the theory and the practice, the routine practice. And what is clearly amazing in this case, I think this patient is now in complete metabolic remission for the first time in her 10 or 11 years history of the disease, which is a very strong marker of the power of these bispecific, especially in her case, elranatamab. And I think we have a question from Dr. Costa, whom I say big hello in Alabama, about the toxicity post-CAR and post-elranatamab. And it was actually quite amazing because she didn't develop any toxicity. So these are a treatment, although we speak a lot about CRS and neurotoxicity, actually it wasn't a matter of concern. And when it comes to infections, and you can expand on this, Florent, because you helped writing some of our SOPs, actually we are extremely cautious and we adopt very stringent prophylaxis and monitoring measures, which allow to avoid these severe opportunistic infections that people are speaking about all the time.
Yeah, I can comment on this point. Regarding the CRS toxicity, in fact, when we use elranatamab, we see some grade 1 CRS in our patients, but this is within the first 10 days. So what we used to do is that we take the patient as inpatient to stop for a roundup of the elranatamab. We manage a grade 1 cytokine release syndrome because it will be very difficult to manage it as outpatient because they still have some fever and this is not comfortable for the patient. But after 2 weeks, we don't see, or this is very exceptional, any cytokine release syndromes with elranatamab, so it's safe from this point of view. It's really easy to manage. Regarding the infection, so of course we need this very close monitoring as highlighted by Mohamad, and in particular we need to monitor for CMV and EBV because we need some CMV reactivation, some increase in EBV. And we need to treat some patients. In fact, in the case of these patients, after 6 months of treatment, she have an increased CMV. It remained borderline for several weeks, and at one point it was too high, and we had to treat these patients. But the treatment was very well tolerated. She was treated as an outpatient, and we don't need to discontinue the elranatamab. Regarding the other toxicity and other infectious complication, we can see this is very important to have the prophylaxis from the pneumocystis jirovecii. We see some patients that did not take the prophylaxis and that developed pneumocystis. We have 2 patients in this case, so if they don't take the prophylaxis, they will have the disease. This is sure. So this is very important to insist on that with your patients on your team. And also we have some bacterial infections. And the question is, do we need to give them some gamma globulin substitution? So this is not standard for all our patients because we are not going just to treat an hypogammaglobulinemia, but if a patient have an hypogammaglobulinemia, have a first pneumonia, she remain in the hospital for 1 or 2 weeks because of that. After we're going to give the gamma globulin substitutions to avoid further severe complications.
So here, please allow me, Florent, to comment on something because you expanded on the safety. And I think there is maybe something specific to elranatamab compared to other bispecific. Of course, we're fortunate having many bispecific under development, and this is definitely great news. However, I believe in this specific case of elranatamab, especially the administration now every 2 weeks, is different from the weekly administration of other bispecific, for instance. And this is maybe contributing actually to the better safety profile while the efficacy remains excellent. And for me, of course, it's maybe speculation because we don't have any head-to-head comparison, but definitely this is something to be taken into account when we consider this issue of T cell exhaustion. So if you allow time for T cells to be less exhausted or to slow down the exhaustion phenomenon, as what has been published in Blood when it comes to a few months ago, I think, about the blinatumomab, then probably, and this is very unique to the schedule of elranatamab. So not only you have quite impressive efficacy, first complete metabolic remission since 10 years in this young patient, And hopefully, I mean, I hope we wish her well, and it will continue for a long time, who knows. And by the way, she has been always fully active, excellent quality of life, doing her job and life. She never acknowledged that she is sick, you know, because she has been always ambulatory. So except for the first auto where she was hospitalized for a couple of weeks. But so this is something important. And the other parameter I would like to highlight, which I learned last week during the COMI Congress from Dr. Bayliss in Calgary, is that at least in vitro, there may be eventually differences between the different bispecific, even if the target is the same. So we may end up in a few months or years that not all the BCMA targeting bispecific are the same, and one may overcome the resistance to another, etc. But definitely the schedule of administration and the way you manage the administration of these bispecific is playing a key role, and the anti-infectious monitoring and prophylaxis is extremely important, especially for viruses, because when it comes to fungal infections, we know that the major, I would say, player would be the neutrophils, so neutropenia, and they don't experience much neutropenia. And we need to acknowledge that these patients that we are treating today with bispecific are patients who are heavily pretreated. They have received tons of dexamethasone. So it's not always like, you know, maybe the bispecific is a trigger, but you need to acknowledge that they have accumulated a lot of previous treatment.
Yeah, so thank you, Mohamad. And by the way, you answer a question by Andrea Amorin that were raising the question of the respective safety profile of different bispecific antibodies. So you are already on record. We have or still some other question in the chat. Some of them is asking. I have one question for Nicolas. In fact, Nicolas, if these patients, of course, as Mohamad said, we wish the best to the patient. If now, unfortunately, there is a relapse, what would be your option for these patients based on what we discussed previously?
Oh, good questions. Thank you. I think that if this patient will relapse in a few months, the next treatment consists to evaluate the expression of the other target and maybe propose a new immunotherapy with targeting the other target. Why not?
Yeah, what? So we can use any new specific antibody. They are all available.
Yes, with another target, maybe the talquetamab, probably.
Yeah, I mean, I agree. I mean, now talquetamab is available, so it's about also in myeloma, the general concept, guys, of buying times. And we are buying times, and the example of this patient is a very good one because it showed us that we can buy time and good quality of life time. So now, and I hope it won't happen soon, we can, in theory, propose another target, another agent with another target like GPRC5D. However, we should not forget when we speak about the bispecific against GPRC5D, also we are excited. They also do have some side effects, especially when it comes to skin, nails, and in my opinion, most importantly, dysgeusia, which can be very bad for the quality of life of the patient. And I think many of us who, for instance, got the COVID infection and lost the taste remember very well that it's not something of course, it's not life-threatening, it can be managed, but definitely that would be the second target to be explored. Also, of course, if cevostamab targeting FcRH5 is available, that can be an option. And we should not neglect, if tomorrow you have also CAR T cells directed against another target, they can be an option. What is more subtle is that if we have today a patient who is relapsing after a BCMA-directed CAR T, would I choose first a BCMA targeted bispecific or a GPRC5D or another? Nobody knows the answer about this sequence. You may think, okay, I want to change the target, but you may say, okay, I can try the same target and leave my other target. I don't know the answer. So, but we will learn more and more. The more we use, we will have more information. I mean, the results achieved in this lady is very unexpected.
Yeah, just one point on this is what you said earlier, Mohamad, regarding, for example, you have a CAR T cell, again, GPRC5D, and you are also a bispecific. The thing is that, as you say, for GPRC5D, we lost the expressions. This is a mechanism of patients relapse. So maybe the sequencing of the CAR T cell on bispecific targeting GPRC5D probably will not be the best options. In contrast, when we target BCMA, maybe it will work better in some patients, as we show here. So this is important to take that into account. And regarding the first line choice, because we have now a lot of treatment options between CAR T cell and bispecific, irrespective of the sequencing, what is the best option for the patient, in your opinion, Nicolas?
Between the CAR T cell and the bispecific antibody?
Regarding the safety and
my feeling is that the CAR T tolerance is better than the tolerance of the bispecific antibody, but we have very many difficulties to obtain the treatment. So actually, we realize a treatment by CAR T cell for few patients, and we probably have more facilities to obtain the bispecific antibodies. But if your question is which treatment is better tolerated, I think is bispecific.
No, CAR T, you say previously.
Oh, CAR T, sorry.
And CAR T, and I agree with that in that point, because of course, there is a cytokine release syndrome. The patient needs to stay in the hospital for 2 to 3 weeks. But after, we must highlight that they become totally outpatients. They don't need to come back to the hospital every week, every 2 weeks, every month to receive a treatment. And for some patients with a 10-year history of multiple myeloma that come all the time in the hospital, when they are disease-free after CAR T cells, this is really important for them, because they can have a real life like before they were sick. So they really enjoy the CAR T cell treatment, even if this is only for 6 months or 1 year that they remain disease-free. So this is really something we need to highlight, that we say that now with bispecific, we'll stop doing CAR T cells, but in fact, I am not sure this is true, and that for the patient's quality of life, even if patients relapse after CAR T cell, if we can give them some treatment, some disease-free and treatment-free time, this is very, very important for them.
Well, I mean, Florent, in general, I would agree with you. At least from a patient point of view, all our patients are asking for CAR T cells. And the beauty of CAR T cells is that it is a single shot treatment. So then the patient will enjoy some treatment-free interval. Having said this, I think I'm not convinced 100% that for the future, it will remain a single shot treatment, because we know there are already some trials being planned or about to start or having started using maintenance treatment about CAR T cells. So that's one parameter. The other parameter that we should not neglect is that the availability. And I do not foresee that suddenly in the next couple of months or several months, we will see easily CAR T cells available to everybody immediately. And the third point, that even if you have CAR T cells available, actually in patient with aggressive and rapidly evolving relapse, it may be too late to wait for the CAR T cells. This is why I'm personally convinced that having the bispecific antibodies available is really straightforward, highly effective treatment option. And I can bet that for the near future, most patients actually will start with the bispecific. Also, another important parameter, and we have seen this with elranatamab in the French compassionate use experience, is that while we make a big buzz about CRS and neurotoxicity, actually they are very mild, and even non-academic center can use them very nicely and without, as long as you deliver some good SOPs about infectious management and prophylaxis and prevention of whatever hypogammaglobulinemia. So this is really a tricky story where you have a big gap between the theory and the reality on the ground. And I think we will have to live with this for many years. Now, the question is, we always claim, and at least the data available showed that CAR T cells are less effective after bispecific. But then the story may be different if you're using a CAR T cell with a different target than BCMA. So if tomorrow you have a CAR T cell with against GPRC5D, the other question is, why not? It's a question mark, I'm just raising a question. Why not storing lymphocyte before starting the bispecific antibody, if we assume that one of the concerns is about availability of fit lymphocyte to generate CAR T cells? So it's a multifactorial. I think the puzzle is quite complex, but we have plenty of small pieces, and it's only about learning and doing things in a very meticulous way, and also observing the patient, the behavior of the patient, like exactly in this patient.
So thank you, Mohamad. And yes, as you say, we are only at the beginning of the story, and I am sure that in the next years, you will still learn a lot of things, and that some stuff we discussed today will be completely out of date with the new data. So we are coming to an end. We are still a lot of questions in the chat, but unfortunately for time's sake, we'll not be able to take all of them. I apologize for my colleagues. Did you have a final comments, Nicolas, Mohamad?
No, really. I just want to thank you for this invitation. It's my pleasure to present all this clinical journey. Very good.
Well, I think it's a very exciting. Well, first, I'd like to congratulate Nicolas for nice presentation and beautiful PET scan. And also, it's a very exciting era for all of us in this field, because these bispecific antibodies are proving to be a true revolution. They are game changer. And without any exaggeration, when you see the story of this patient, how she responded and achieved complete metabolic remission to elranatamab after failing 6 or 7, she was pentarefractory. That was. And please don't forget, we didn't mention this, but the PFS of the pentarefractory patient is less than 3 or 4 months. And here we are already in someone where you are in complete metabolic remission. We didn't check, I think, for the MRD negativity, but definitely it's a good start for the future. So it's about buying time. Sometimes it's purely empirical, but it is worth it, in my opinion, as we could see from this case.
So thank you again, Nicolas. Thank you again, Mohamad, for these very amazing discussions. And just keep posted for the next ISH Junior Club that will come very soon. So see you soon. Bye.
Thank you.
Bye.